Ma'am, we are on live and we are starting session, ma'am. So very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. The topic for today's webinar is poor responders and its management. And I welcome all the participants and request them to post their queries, if any, in the chat box, so that we can have a short Q&A session at the end of this presentation. And now it's time to introduce our invited speaker for the day, Dr. Nidija, ma'am. Madam has done an MBBS MS, and Madam is currently the senior consultant at Nova South End Fertility and IVF Center, New Delhi. And Madam was also the founder and director of Care and Cure Clinic, New Delhi. And Madam was the past assistant professor at SGT Medical College, Gurgaon. So with this short introduction, I welcome you, ma'am. I'm handing the session to you for your proceedings, ma'am. So welcome, ma'am.
Thank you, Dr. Stalin, for the great introduction, and welcome everyone on this not exactly winter afternoon, spring afternoon, and it's a very pleasant weather outside here in Delhi. And yes, it is a topic very close to my heart. Being an IVF specialist, these days we cater a lot of poor ovarian responders. So, and these are actually the real difficult cases where you don't feel that you'll get less number of eggs. And when you do ovum pickup and you're not very happy with the number of eggs you have got. So I'll be talking in detail about the poor ovarian responders. I'll start sharing my screen, Dr. Stalin.
Yeah, ma'am, please, ma'am. Yes, ma'am, it's visible, ma'am.
Yeah. So poor responders and management is today's topic. So first of all, we should know what exactly is the poor responder. What do we mean by this term? Is it reliable? What can we do about it? What might we be able to do about it? Poor ovarian response. Poor ovarian response, failure to respond adequately to standard protocol.
Yeah. Sorry, ma'am, the slides are not moving, ma'am.
Not moving. Is it moving now?
No, ma'am, it's not moving.
Was it moving earlier?
No, ma'am, we can see the first screen. Now, ma'am, you can just click on the screen and you can go for the next. Yeah, ma'am.
No, here I can, I see that I'm able to change the slides. So the change is not visible to you?
No, ma'am, I can see the first screen, ma'am. First slide, first page of your slide, but not.
No, I understand that. Do you have the slides with you? You can arrange from your end, or should I send it to you?
Yeah, ma'am, you can send it to me so that I can send
them. Send me a hi if possible.
Yeah, ma'am. Yeah, ma'am. Ma'am, I don't have your WhatsApp number, ma'am. I will send my mail ID to you so that.
Okay.
PPT. 1 second, ma'am. 1 second.
Because from my end, I am able to change the slide. I don't know.
Ma'am, or you can just stop share and reshare again, ma'am. Once.
I think so. That will help. I'll reshare it.
Yeah, ma'am. Now it's moving. Now it's moving, ma'am. Yeah, ma'am. Now it's moving, ma'am.
Okay. Yeah. So the poor responders, what do we mean by this term? Is it reliable? What can we do about it? And what might we be able to do about it? Poor ovarian response, as you know by the name, failure to respond adequately to standard protocols and to recruit adequate follicles. Result is decreased oocyte production, cycle cancellation associated with diminished probability of pregnancy. A poor responder was first described in 1983 as one who, on a standard stimulation regime, 150 international human menopausal gonadotropin had a peak estradiol concentration of less than 300 picogram per ml, and who had poor follicle production, leading to a smaller number of eggs retrieved and therefore a smaller number of embryos transferred. Definition by ASHRAE, European Society of Human Reproduction and Embryology. At least two of the following three features must be present: advanced maternal age or any other risk factors for poor ovarian response, a previous poor ovarian responder, and an abnormal ovarian reserve test. At least two of the following three features must be present. 2 episodes of poor ovarian responder after maximal stimulation are sufficient to define a patient as poor responder in the absence of advanced maternal age or abnormal ovarian reserve test. So if you have a patient who has twice responded poorly to the standard stimulation protocol, you don't have to take in consideration the other two factors. So European Society of Human Reproduction and Embryology, again, the term POR refers to the ovarian response, and therefore one stimulated cycle is considered essential for the diagnosis of poor ovarian responder. It is very, very important to understand the difference. Poor ovarian, POR is poor ovarian responder. It's not poor ovarian reserve. Sometimes we get confused by the name. Poor ovarian, the better term for poor ovarian reserve is diminished ovarian reserve. POR is ovarian response. Patients of advanced age with abnormal ovarian reserve test may be classified as poor responder, since both advanced age and abnormal AORT may indicate reduced ovarian reserve and act as a surrogate for ovarian stimulation cycle outcome. In this case, the patient should be more properly defined as an expected poor responder. So in patients where advanced age is there and ovarian reserve testing is also showing poor ovarian reserve, then it is an expected poor responder. It is, if the cycle is not done earlier, it can't be classified as poor responder. Is this problem frequent? This is a very important question. The occurrence of poor response to ovarian stimulation is not infrequent. The prevalence of poor responders varies in the literature between 9 and 24%. 24%, even 1/4 of the total IVF cycles can be poor ovarian responder, which is a very huge number. This range is wide as it depends on the definition of a poor responder that individual IVF centers employ. Things are more standardized now. Data from American Association of ASRM and SART registry showed that 14.1% of initial cycles were cancelled. At least 50% of these were poor responders. Suggested etiologies why poor ovarian responders exist, why poor ovarian response happens. The etiology of poor response to ovarian stimulation is unknown. Despite being highly correlated with maternal age, the condition is also common in younger women in whom low ovarian reserve represents the most frequent etiological factor. Low ovarian reserve may be associated with advanced endometriosis, prior ovarian surgery, pelvic adhesions, increased BMI, or smoking. These are very common causes of low ovarian reserve. This condition might also occur unexpectedly in young women who are non-smoker and have apparently normal ovarian reserve. This last kind of patient, a non-smoker girl, young girl, and she has normal ovarian reserve, but still she has a poor ovarian response. These kind of patients are increasing in number lately. What is the possible mechanism? Poor ovarian response is the first sign of ovarian aging, early ovarian failure, or or menopause before time. Suggested mechanism for poor ovarian response: decreased number of FSH receptors in granulosa cells, defective signal transduction after FSH receptor binding, and inappropriate local vascular network for the distribution of gonadotropins, the presence of autoantibodies against granulosa cell, and excess of vascular growth factor receptor 1, abnormality in IGF-1 and IGF-2 levels, and diminished circulating gonadotropin surge attenuating factor bioactivity. So as you can see, the problem is occurring at the receptor level and receptor binding level, even at the level of vascular growth factor receptor. So it is mostly at molecular and receptor level. Can poor ovarian response be predicted? Very, very important question. Difficult to predict who will be a poor responder. If you are able to see, if you are able to understand anything beforehand, in those cases, you are able to counsel your patients that way. But many a times, most of the times, these poor responders, it is a surprise for you. So you are not able to explain your patients poorly, and you have to think of answers when it happens. Stimulation protocol should be individualized according to the condition of each case. That all of we have been doing, which is known as ICOS, individualized controlled ovarian stimulation, what we do these days. Several tests have been proposed to predict ovarian reserve, which can give an idea about the ovarian response. So high levels of serum FSH more than 12 or more than 15 milli-international unit per ml on cycles day 2 or day 3. So this FSH level more than 12 or more than 14 in itself says that there are chances. This is a very important ovarian reserve test, and it says that there is decreased ovarian reserve. In regularly cycling females, only high level of basal FSH is an accurate prediction of this. This test is not suitable as a diagnostic test, but only as a screening one for counseling purposes in the first IVF attempt. So if you are getting FSH levels so high, you can counsel your patient that she might behave, even if you are able to see more number of follicles on the ultrasound, she might behave as poor ovarian responder. Elevated FSH by LH on day 3 blood test, that also is very important. Elevated levels of serum estradiol more than 30 or 75 picogram per ml on cycle day 2 or day 3. So many of the centers like us, we don't start cycle if the estradiol levels are more than 75 picogram per ml, because it might be a predictor of poor ovarian response. The clinical applicability for basal estradiol as a test before starting IVF is limited by its very low predictive accuracy for poor response. The clinical applicability, they say that of basal estradiol level is not as great as serum FSH, but yes, we do take that value, and it's better to take. Decreased level of serum inhibin B, less than 45 picogram per ml on cycle day 2 or 3 are also able to predict it, not very accurately, but it might be a predictor. In regularly cycling women, basal inhibin B is accurate only at a very low threshold level. Reduced production and bioactivity of GNSF, low insulin growth factor 1 in the follicular fluid, decreased serum concentration of AMH. Most of it, or all of it, are marker of ovarian reserve, poor ovarian reserve. Sonographic test, as all of us know, decreased ovarian volume. It is hardly suitable as a routine test. We don't consider it much, but yes, it has been seen that if the ovarian volume is very less, antral follicles also number, most of the cases are less only. A meta-analysis showed that ovarian volume measurement with cutoff value of this, the specificity for the prediction of cycle cancellation and non-pregnancy of 92 and 93% respectively. We don't take this in consideration. Decreased antral follicle count, which is a very, very important factor. The accuracy of the antral follicle count for predicting poor response in the regularly cycling women is adequate at low threshold level. It will not be suitable as a diagnosis. See, whenever we are talking about this diagnostic test for poor ovarian response are very less, and there's nothing diagnostic, I should say. But it may be used as a screening one, directing further diagnostic steps in the first IVF attempt. Another meta-analysis showed that women having AFCs less than 4 were more likely to have cancelled cycle and less likely to get pregnant than women having AFC 4 or more, which sounds very valid. Decreased ovarian stromal blood flow. The clinical value of Doppler studies for ovarian stromal blood flow has been unclear. Dynamic test, the Clomiphene challenge test, it performs no better than other tests like AFC or basal FSH. So these are the tests mainly for theoretical purposes. We generally don't do it on daily basis. Exogenous FSH ovarian reserve test, the GnRH agonist stimulation test. When used in regularly cycling women, GST showed a high degree of accuracy in the prediction of poor response that could match that of AFC. However, it can be a candidate for more extensive confirmation. In regular practice, generally we don't do. What is our goal? Why are we talking and why are we so scared of this poor ovarian response? Our goal is to maximize the oocyte yield, increase the chance of having at least one euplide embryo for transfer, and increase implantation rate. That is very, very important. That is our goal. Patient-oriented, now coming to the most important, the Poseidon group. Patient-oriented strategies encompassing individualized oocyte response, Poseidon group. And this is a fertility and sterility study. A new, more detailed stratification of low responders to ovarian stimulation from a poor ovarian response to a low prognosis concept. This article, low prognosis groups. So there are 4 groups of Poseidon classification. One is adequate ovarian. Group 1 is patient with adequate ovarian response. Age is less than 35. AFC is more than 5 or AMH is more than 1.2 nanogram per ml. This has 2 subgroups. Subgroup 1A, which has subgroup 1A has the marking less than 4. Subgroup 1B has the total number of 4 to 9. In the same group, when the age is more, AFC and AMH seems similar. Subgroup 2A is when we get the eggs less than 4, and subgroup 2B is when we get the eggs 4 to 9. Poor ovarian reserve, female, young female with poor ovarian reserve, AFC is less than 5, AMH is less than 1.2, and group 4 consists of older women with with poor ovarian reserve, AFC less than 5 and AMH less than 1.2. So the first class is hyporesponder and or suboptimal responder, and the second class is expected poor ovarian responder. Low prognosis owing to decreased number of oocytes, thus negatively affecting the outcome. Poseidon, as you can see, poor is 1 to 3, and it has been seen in 21.7%. Suboptimal 4 to 9, 39.7%. Normal will be where the oocyte retrieved were 10 to 15 has been seen 50%, and high is always more than 15 oocytes retrieved, and it was seen in 61.5% of females. Female age influences oocyte and embryo genetic quality. 35 and over, blastocyst euploid probability decreases by 50% overall. So when we compare females of more than 35 to less than 35, if the females in the females of more than 35-year-old age, there is as big as 50% fall in ovarian response. Low embryo aneuploidy risk. Group 1 is young, suboptimal, low oocyte number, as we saw earlier. Group 2, old, suboptimal, low oocyte number. Group 3 is young and expected low oocyte number. Group 4, the similar classification we have read earlier. Few embryos were generated, reduced cumulative live birth rate. And group 1 and 3 has the low embryo aneuploidy risk, and group 2 and 4 had high embryo aneuploidy risk. Prevalence of low prognosis patients according to Poseidon. If it is 1 to 4, the risk is very high of not getting pregnant. Gonadotropin starting dose and regimen can be determined in all patients. Poseidon-based stratification. Non-Poseidon means good ovarian reserve, has very good prognosis. As the grading goes towards G1 to G4, the prognosis worsens. Poseidon-based stratification. Step 1 is Poseidon-based stratification. Step 2, estimate the minimum number of mature oocyte needed to have at least one euploid blastocyst for transfer. Step 3 is patient-oriented treatment strategy to achieve the individualized oocyte number. See, whatever classification we do, our ultimate goal is to get at least one euploid embryo. So the most optimal treatment strategy is planned with the mindset to achieve Poseidon marker for success. GnRH analog regimen, gonadotropin dose and drug type trigger strategy, adjuvant therapy, combined strategies, personalized use of laboratory technology, personalized luteal phase support. So these are the points where we can, these are the things where we can put effort and try to yield more number of oocytes, euploid oocytes. Non-Poseidon patients, high responders are aim in high responder is to obtain oocyte and in particular avoid the risk of OHSS. GnRH, ANTAG, RFSH only, pen device, GnRH trigger. These are the safety measures we take for high responders. Normal responders, aims are to individualize number of oocytes with less drugs and short treatment duration. Agonist or antagonist, in these cases you can take both RFSH alone or you can take RFSH plus RLH, HCG or agonist trigger. Any of these will be given. It is important to, just a moment. It is important to use the right FSH starting dose and adapt it during the cycles to optimize the number of oocytes retrieved and at the same time minimize risks such as OHSS and cycle cancellation. So whenever we talk about low response, optimal response and high response, so all our efforts are generally towards normo-responders. If it is a high responder, we are scared of OHSS, and it's a low responder, there are chances of cycle cancellation. So always, as in everything, mid path is the best. Oocyte yield per gonadotropin type, recombinant FSH has more than urinary FSH, HMG. So in this article, they have seen that they got best yield with GnRH antagonist, more 3.1 oocyte, and GnRH agonist protocol after that. And the worst one was GnRH antagonist protocol first type. A comparison of menotropin and folitropin alpha in ICSI cases. Recombinant FSH was given, highly purified HMG was given, and HMG per se was given. So the doses were recombinant FSH was 6,324, highly purified, the dose was increased, and normal HMG dose was further increased. So according to this, recombinant FSH works better. Individualization in non-Poseidon patients. In hyper-responders, we need to avoid OHSS and fully control the cycle to achieve the individualized oocyte number. Recombinant FSH better safety profile is, for example, small dosing adjustments, GnRH NTAG protocol and GnRH agonist trigger. LH supplementation is not essential. So these are the factors, these are the points we always take when we think of a patient with a hyper response. In normal responders, we need to increase success by achieving the individualized oocyte number with lesser drugs and shorter treatment duration. Recombinant FSH increases oocyte yield. LH supplementation not essential, but in older patients, GnRH and TAG protocol and HCG trigger. So in normoresponder, your main aim is to individualize oocyte number. The number you are seeing there on the ultrasound screen, you want the number of follicles. You want to at least get those number of follicles. And in these cases, it is seen that LH supplementation is not always required. But LH supplementation is good in high responders. Gonadotropin starting dose and regimen can be determined in all patients. So as we see, the grading is increased, prognosis is poor. Understanding ovarian hyporesponse to exogenous gonadotropin on ovarian stimulation and its new proposed marker, follicle to oocyte index. This is a very good index. Classic poor responder and hyporesponder. So the Bologna criteria, at least two of these conditions. Advanced, you have seen the Poseidon previously. Now we are comparing it with Bologna. At least two of the three conditions below. Advanced maternal age. There you can see, you have seen that advanced maternal age there in Poseidon, we take more than 35. In Bologna, we take more than 40. Or risk factor for poor response like Turner, X-fragile, chemotherapy. So you know there are other factors as well for poor response. Less than 3 oocytes previous stimulation with the conventional protocols. If you remember in Poseidon, we were taking 4, more than 4. AFC 5 to 7, AMH less than 0.5 to 1.1. There we were taking AFC less than 4 and AMH we were taking less than 1.2. Hyporesponders in the Poseidon group, normogonadotropic women, adequate ovarian reserve, biomarkers, unexpected suboptimal response, that is 4 to 9 oocytes, or poor response, less than 4 oocytes with conventional protocol. Adequate oocyte number we were taking there is more than 9 oocytes at expenses of longer duration of stimulation and higher amount of FSH required. So very, very importantly, normal FOI more than 50% was seen in grade 1 and grade 2. Low FOI was seen in grade 3 and grade 4. Poseidon management of low prognosis patients, adequate AFC or AMH previous cycle with poor or suboptimal oocyte number. By now you know all this. So group 1, young and less than 35. Possible reasons, low gonadotropin, why it was ovarian response was poor in previous cycle. Low gonadotropin starting dose, asynchronous development is a very, very important thing. It can, even in a normal responder, you get poor number of oocytes if the growth is asynchronous. Genetic polymorphism, and that also is very, very important. FSH receptor polymorphism should be ruled out. Trigger and or oocyte pickup issues. So these can be the factors when in a group 1 young female we have seen previous poor ovarian response. So ICOS treatment, GnRH and TAG protocol, we go for rFSH in preference over urinary FSH or HMG. In the previous article, you have seen that rFSH dosing also is required less, and it gives you better response as well. Increase the rFSH dose, increase the RH and add RLH supplementation. So in a young female with unexpected poor response, if you change from UFSH HMG to rFSH, it is a better idea, and you should add RLH as well. Transfer strategy, HCG trigger or dual trigger, or GnRH agonist trigger, but always in ovarian poor ovarian responders, we always try to keep it as HCG trigger or dual trigger. Fresh transfer, I'm not very confident with the agonist trigger in these cases. Fresh transfer if no risk of OHSS. Elective cycle. This is very important. Freeze all in all the cases are not required. We have our own data where we do for poor ovarian response, and even for poor ovarian reserve patients, we try to do fresh transfer. Fresh transfer because if you have lesser number of follicles, there are less disharmony of the hormones, and you should always give you should always try to give at least one fresh transfer in these kind of patients. Elective cycle segmentation and FET if risk of OHSS or PGTA. PGTA is always good because you are able to exclude better embryos than worse embryo, not very good aneuploid embryos. So PGTA, it is a very good thing, but yes, it involves cost. But in these kind of patients where we already know that they have gone for poor ovarian response once, so there is some inherent problem. So giving them an option of PGTA is not bad. Measure of success, as always, number of oocytes needed to obtain at least one euploid blastocyst for transfer. Overall, a minimum of 5 mature oocytes is needed. So one euploid blastocyst, you need generally 5 mature oocytes or M2 oocytes. Group 2, where the age was more than 35 and reserve, but good reserve was there and poor quality was there. Possible reasons is very important. Low gonadotropin starting dose, as we saw in younger age group. Asynchronous development, here also similar things, genetic polymorphism, trigger or oocyte pickup issues. ICOS treatment, as it is OCP priming in good reserve, they said OCP priming and E2 or norethistone priming they are given. Here also the similar thing can be tried. Increase rFSH dose, that is very, very important. LH supplementation and duostim. Duostim is a very good thing. Earlier we used to do that for
I don't know that.
earlier we used to do this for our cancer patients, but now I would, for my poor ovarian responders and even poor ovarian reserve patients who have less time in hand, duostimulation gives much better result. So trigger and transfer strategies, previous slide. trigger and transfer strategies. HCG trigger, dual trigger, agonist trigger, fresh transfer if no risk. There are similar things. PGTA here also, they have said, measure of sexes, number of oocytes needed to obtain at least one euploid blastocyst for transfer. Overall, a minimum of 10 to 12 mature oocytes is needed. See, very, very important, how much age makes a difference. Here you can see you need 5 mature oocytes in less than 35 years age. You need 5 mature oocytes for one euploid blastocyst. But in this age group, more than 35, it is 10 to 12 mature M2 oocytes to give rise to one euploid blastocyst. That's why we keep telling our patients that come to us at a younger age. We'll be able to do more justice with you. In this article from Fertility and Sterility, populations investigated hyporesponse to recombinant FSH, advanced reproductive age, co-treatment with GnRH antagonists, profoundly suppressed LH levels after the administration of GnRH agonists, normo-responders with risk of OHSS, poor responders to ovarian stimulation, including those who met the Bologna criteria. And what all we saw, the main outcome measures were implantation rate, number of oocytes retrieved, live birth rate, ongoing pregnancy rate, fertilization rate, and number of M2 oocytes. So number of M2 oocytes is always a very good outcome measure. So what the results said? Results said hyporesponders, number of studies were 4, participants were 672. They were given RFSH plus RLH in comparison to only RFSH. Better number of oocytes retrieved and implantation rate was improved. So hyporesponders, we have talked earlier as well, RLH supplementation will give you a better result. So advanced age here also, they have added RLH and they have got better response. This article was taken from Reproductive Biology and Endocrinology. The role of recombinant LH in women with hyporesponse to controlled ovarian stimulation, a systemic review and meta-analysis. Hyporesponders, initial slow response on stagnation in follicle growth during ovarian stimulation with FSH monotherapy, absence or marginal growth of both follicles and estradiol levels during ovarian stimulation. A hyporesponse can be retrospectively diagnosed in women who require higher than expected dose of gonadotropins on the basis of age, BMI, and ovarian reserve. In these kind of patients, when we have added LH, it has improved our outcome. Administration of appropriate gonadotropin dose and regimen critical to allow growth of more number of follicles and hyporesponders, type of gonadotropin, FSH dose, LH supplementation, everything makes a difference. Low follicle oocyte ratio was of less than 50% was seen in group 1 and group 2 when RLH was not given. So coming to management of group 3 and group 4, we have seen group 1 and group 2. Group 1 is less than 35 years of age with good reserve. This was the 2 was more than 35 with good reserve. Group 3 is now less than 35 with poor reserve. Reason for ovarian response, poor ovarian reserve, which in itself is a big reason. Asynchronous development, as we saw earlier, genetic polymorphism also we saw earlier. In group 4 also there was similar things, but one important difference was high aneuploidy rate, because the age is more than 35, so high aneuploidy rate. ICOS treatment for group 3, long GnRH agonist protocol, GnRH antagonist, duostim, stimulation with 300 IU RFSH, androgens, growth hormones. These were done. These can be tried in group 3 and similar in group 4 as well. Long GnRH antagonist protocol, everything was similar. Everything given tried is similar in both the groups. Embryo transfer strategy in both fresh transfer, oocyte embryo accumulation and FET. Because in group 4, as we saw, the age is more and there are more chances of aneuploidy. So oocyte embryo accumulation, PGS was advised, PGTA was advised, and frozen embryo transfer also done. Measure of success: in average, a total of 4 to 5 oocytes are needed to obtain a euploid embryo. Earlier also in Poseidon 1, we have seen the same thing. Measure of success, again, the age is more than 35. So total of 12 oocytes are needed to obtain 1 euploid embryo. Age makes a lot of difference. So advanced age 35 to 39, number of studies were for participants 578. Here also RFSH and RLH was done and it was compared with plain RFSH. It showed better implantation rate. Conclusion, coming to the conclusion, only female age and number of oocytes can predict live birth rate. As all of us know, Poseidon criteria offer the possibility to refine the stratification of patients undergoing ART using age, number of oocytes, and ovarian reserve biomarkers. Patient-oriented strategies to achieve the individualized oocyte number can be applied using the Poseidon criteria. Increasing oocyte yield is an opportunity to have more euploid embryos with a positive effect on implantation and cumulative pregnancy rates. It is important to use the right FSH preparation and starting dose. Starting dose is a very, very important thing, and right FSH preparation. See what you are using and in what dose you are using. That is in what is your starting dose. These two factors are very, very important. The dose during the cycle to optimize the number of oocytes retrieved and at the same time minimize risks such as OHSS and cycle cancellation. Administration of appropriate gonadotropin dose and a regimen critical to allow growth of adequate number of follicles in hyporesponders. LH supplementation should be individualized in line with modern patient handling approaches. Greater clinical benefit in hyporesponders and women aged 35 to 39. RLH is a very expensive thing, and we should not prescribe it to patients right, left, and center. Clinical benefit is more seen in hyporesponders and women aged between 35. So if the women is more than 35 years of age, the requirement is more justified. Thank you for your patient hearing. Very importantly, I would like to say the conclusion. I have not included this point, but a very important point here is asynchronous growth of the follicle. There are multiple ways of decreasing the asynchronicity. I'll show you asynchronous. So if you are able to synchronize your stimulation, that is a very important factor, and you can do it by pre-treatment with either estradiol or OCP or progestin. So that is very, very important. Asynchronicity, if you have seen in the previous cycle that there is asynchronous growth, pre-treatment with estradiol or OCP or even agonist for that matter helps you in increase number of yield of oocytes. Thank you very much. Thank you for your patience.
Thank you, ma'am. Thank you very much for that detailed presentation, ma'am. Based on your presentation, we can conclude like patient-oriented approach and rather patient individualization. And the dose and time for oocyte optimization is very vital for these poor responders. Thank you, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. If there is any queries, then I'll read it for you, ma'am.
Okay.
Ma'am, what will be the best these protocols, ma'am, in low responders, like agonist or antagonist will be a better one, ma'am?
See, as I said, if in my experience, when we do async, you do see asynchronous growth in, because definition only says poor ovarian responder. So to be a poor ovarian responder, you must have seen her previous cycle. So if in the previous cycle you have seen that there is asynchronous growth, then it is better to go for long protocol, or there are different other AACEP protocol or estradiol priming. These things will lead to lesser asynchronicity. So these kind of patients, it's always better to go for long protocol or with estradiol priming. And otherwise, as such, if you have seen the patient with older age group with poor ovarian responder, the starting dose is very, very important. Starting dose with even NTAG gives a better response if you start with RFSH, adding with RLH, and the starting dose is good. In these cases, generally I feel that if they are not hyper responders previously or something like that, you are not expecting, the number of follicles are not very high. In those cases, it's always better to start with a higher dose.
Okay, ma'am. Ma'am, what will be the role of these supplements, ma'am, like arginine, leucine, and any other supplements like minoxidil?
Nitric oxide dilators, they say that it improves, like arginine, as you said. See, we are looking for adjuvants. Okay. I feel that these, you don't know what will make a difference. You don't know. So we try, in these cases, we try to give antioxidants, we try to give vitamin C, we try to give nitric oxide dilators. Sometimes we even give growth hormone. So I think only growth hormone is one thing which is which has been shown a big difference. But yes, I have seen some oocyte quality improvement I have seen with adjuvant. So I always feel that you should give them their best. Most of these medication does not hamper anything. If you are giving antioxidants, that is helping in them in other things as well. So if you have the option, I always feel that adding adjuvant helps.
Fine, ma'am. Ma'am, there is no any other questions in the chat box, ma'am. So if you allow us, then we can end the webinar for today, ma'am. If there is any question, I will share it with you through your mail ID, ma'am. You can address all those queries, ma'am.
Definitely.
Thank you, ma'am. Thank you for being with us today and spending your valuable time.
Healthcare to which offers the platform.
We are looking for many more webinars from your end, ma'am. Thank you, ma'am.
Yeah, definitely.
I'm ending the webinar.
Thank you.
Thank you.